Good afternoon, everyone. Thank you for joining us today for the next installment in our price transparency series, Industry Perspectives on Good Faith Estimate Requirements. In today's webinar, we'll start off with some background on CAQH Core and our vision and industry role. Then we'll provide some background on good faith estimate requirements. Finally, we'll get into the meat of the presentation, which is a panel discussion with our two speakers and CAQH Core staff. Finally, we'll get into a questions and answers period. Looking into logistics for today's presentation, you can access webinar materials from the handout section of the GoToWebinar menu. You can also download the slides and recording on our event page after the webinar. The slides and recording will be emailed to all attendees and registrants in the next 1 to 2 business days, and feel free to forward them to anyone in your organization who might also be interested. Questions can be submitted at any time using the questions panel on the GoToWebinar dashboard. I want to give a big thank you to our speakers. Ronnie Eldawani is the Director of Product at Athena Health, leading the patient payment space. He manages multiple development teams within the revenue cycle management workflow, focusing on critical business problems, including patient eligibility, cost transparency, and flexible payment options. He is also the program lead for No Surprise Billing at Athena and has delivered solutions for insured patients, and is currently building solutions for self-pay cost automation. He lives with his wife in Wayland, Massachusetts, and they are expecting their first baby later this month. Next, I want to introduce Kevin Mulcahy. Kevin joined the Massachusetts General Physician Organization Professional Billing Office and is currently the Senior Director of Provider and Payer Service, overseeing the payer relations, contract management, special billing, and provider enrollment departments. In this capacity, he is responsible for the development of relationships with the payers on behalf of the physicians, professional billing office, and oversees the contract management system identifying payment trends. In 2019, he took on the oversight responsibilities for the provider enrollment activities. He's the current president of the local MARA MGMA, as well as a member of the MGMA Government Affairs Committee and a fellow in the American College of Medical Practice Executives. He's also a board member of CAQH Core. He and his wife, Jen, have 2 grown boys and reside in Milford, Massachusetts. I also want to thank Taha Anjawala, Associate Director here at CAQH Core, and Caitlin Powers, who's also a Senior Associate at CAQH Core. We have a wealth of experience on the panel today. And with that, I will hand it over to Taha Anjawala.
Thanks, Daphne. So on the next slide, before we dive into talking about the No Surprises Act and hear from our panelists on their implementation perspectives, I'd like to provide some background on CAQH Core and our role within the healthcare industry. CAQH Core, which CAQH stands for the Council for Affordable Quality in Healthcare, and Core Committee on Operating Rules and Exchanges, is an industry-led multi-stakeholder initiative that drives the creation and adoption of healthcare operating rules that support standards, works to align administrative and clinical systems, and accelerate interoperability between stakeholders. Core is designated by the Department of Health and Human Services as the national operating rule authoring entity for HIPAA-covered administrative transactions, and we work to execute our rule development efforts through launching various work groups on priority topics identified by our members. And for today's conversation, the No Surprises Act, looking in particular around the good faith estimates and advanced EOBs, was a highly prioritized topic by stakeholders for us to work on. On the next slide, I mentioned the word operating rules quite a few times. So for those new in the audience, you may be asking, what are exactly operating rules? The purpose of operating rules is to support, I believe it's on the next slide. So Core has published 8 sets of rules to date that really help to improve different components of the revenue cycle and touch fee-for-service and value-based transactions. The rule sets highlighted in purple are federally mandated and required for adoption. And operating rules really help to define roles and responsibilities, establish care guidelines for each participant in the information exchange. These rules ensure millions of transactions occur smoothly and easily each day. And the rules facilitate many high volume transactions that involve multiple parties and can even go beyond healthcare, such as with automated banking transactions and airline ticket booking. And as we work with industry today and hear from our conversation guest speakers on the No Surprises Act and what their implementation are, CORE is looking at what is industry perspectives and how can we facilitate broader adoption and implementation through potential operating rules in the future, and that's part of our next steps. So on the next slide, I believe I'd like to hand the call over to Caitlin Powers, who will provide a level set on the No Surprises Act and provide a brief overview of the most recent policy updates that are occurring in the industry. Caitlin?
Thanks, Taha, and thank you for the overview of the CORE. So the advanced explanation of benefits and good faith estimate requirements were established in the No Surprises Act. Late August, HHS delayed enforcement of the advanced EOB and only required good faith estimates to be provided for uninsured and self-pay patients starting January 2022. During focus groups we held earlier this year, we know that providers have been implementing more processes than health plans to meet these requirements. Next slide. We won't go into detail, but here is a list of requirements that have been provided to satisfy the creation of AEOB and good faith estimates. Next slide. And despite that long list of requirements for the advanced EOB and good faith estimates, there's still a lot of questions around their creation and implementation. At the federal level, HHS issued a third final rule with FAQs and a request for information this year. Next slide. The RFI asks over 30 questions regarding implementation considerations for the AEOB and GFE. The main categories of questions are here for your review. We're working on our response here at CEQH CORE and hope to gather information during today's discussion to include. If you have any questions, please reach out to us. And with that, I'll hand it back over to Taha.
Thanks, Caitlin. So over the next several minutes, I'd like to walk over 2 workflows that will help frame and scope our conversation with our guest speakers. Additionally, we will be asking the audience to respond to a few polling questions to get a pulse on where everyone is with their implementation journeys. The visual on this slide shows what a sample good faith estimate workflow looks like for an uninsured scenario. Starting at number 1, an uninsured or self-pay patient schedules an appointment or requests an estimate from a provider. Moving to number 2A, the commuting provider contacts a co-provider or facility to gather estimates of services or items to be rendered by other parties. I like to notate that HHS has exercised an enforcement discretion on this step through December 31st, 2022. Next, at number 2B, the convening provider is required to prepare a good faith estimate within the timeframes listed on the slide. And looking at the last step, number 3, the good faith estimate is then delivered to the patient by the provider or facility. With that, I'd like to hand it over to Daphne for our polling question number 1, that kind of walks through and gets a pulse on implementation timelines from the audience on, what is their perspectives and timelines for implementing the uninsured scenario.
Thanks, Taha. I've launched the poll. So what is your organization's anticipated timeline for implementing and supporting the exchange of good faith estimates for a single convening provider for the uninsured self-pay scenario? And you can select which of the following applies to your organization. Back over to you, Taha.
Thanks. So visual on this slide shows what a sample advanced EOB workflow looks like and applies to the insured patient scenario. Starting at number 1, a patient schedules a healthcare service appointment with a provider or requests an estimate. Moving to number 2, a provider then verifies a patient's insurance coverage with the health plan to determine patient eligibility and benefit information for the healthcare item or service. Transitioning to steps number 3 and number 4, a provider must prepare and send a good faith estimate of expected charges for the healthcare service, including billing, procedure, and diagnostic codes to the health plan. After a health plan receives the good faith estimate, step number 5 would apply, where a health plan must prepare an advanced EOB of expected charges and member liability. After the advanced EOB is prepared, we move into number 6 of the workflow, where a health plan is required to send the advanced EOB to the member and optionally to the provider or facility. And with that, I'd like to move into the next polling question. And this polling question is asked about, what the audience pulse is for their implementations on the advanced EOB scenario for the insured patients. Back to you, Daphne.
Thanks, Taha. I'll give it a few more seconds. Thank you all for your feedback here.
Thanks. And looking at the different messaging standards that could be used to facilitate and exchange good faith estimates or advanced EOB, there are a variety of agreed upon methods on how data should be formatted and structured to really support interoperable data exchanges. The healthcare industry is currently evaluating multiple different approaches that could support good faith estimate implementations. These approaches include standard-based solutions such as the use of the X12 837 predetermination claim transaction, which works in parallel to the claim process today, and consideration for HL7 FHIR through the use of the DaVinci Patient Cost Transparency Implementation Guide. Looking at non-standardized methods, these include the use of good faith estimate templates that could be sent over a web portal, fax, or secure email, or the use of proprietary message formats. Ideally, as the healthcare industry evaluates options on how to exchange good faith estimates and advanced EOBs for services between providers and payers, it's a good idea for standard-based approaches to be pursued. And with that, we lead into our last polling question. And this polling question asks about, what is industry considering and working and evaluating as far as the different messaging formats for good faith estimate processing. We're interested to hear from the audience of what different methods they're considering for implementation. So Daphne, over to you for the polling.
Yep. Poll has launched, and we'll give it a few more moments before getting into the rest of the presentation. Thank you, everyone. And back over to Taha for next steps.
Yep. So in looking at what's next related to good faith estimates and advanced EOB guidance for CORE, we're currently engaged with the CORE board and our participating organizations to draft a response to the RFI that Caitlin talked about earlier. We hope to share our RFI response and provide a summary of responses submitted by industry with you via webinar in Q4 later this year. So stay tuned for more information and registration details in the coming weeks. In the meantime, if you're interested in engaging in No Surprises Act work, there are many industry initiatives underway that are tackling specific use cases. These include work groups led by the DaVinci Accelerator by HL7, WEDI, and X12. CORE is involved and engaged across all these initiatives and ensures to ensure industry alignment across all the different work efforts. So now I'd like to transition our call to our panel discussion and have a conversation with our guest speakers who will provide perspectives on GFE implementations within their organizations. And with that, I'd like it to open up for panel discussion and invite Kevin and Ronnie to the conversation. So in looking in terms of implementation processes, this question is for both Kevin and Ronnie, but maybe I'll have Kevin if you want to start. Would you be able to walk us through your implementation journey of how your organization is supporting good faith estimate requirements to date, and maybe talk about where you are in terms of your end goal?
Sure. Good afternoon, everyone. For those of you that don't know, the Mass General Physicians Organization is part of the MGB health system here in Massachusetts. We are a mixture of academic medical centers, specialty hospitals, acute care hospitals, and over 8,000 providers. We started talking about no surprise billing last year during 2021 and kind of kicked it into high gear in early 2022 and broke it down into several different areas of focus and our strategy as a system. We are operating as a system and putting processes across the board for dealing with no surprise billing. As it comes to the good faith estimates, we have AOB on hold for right now. We are waiting for additional information before we go and try to plug it in, because there's state level initiatives as well that we have to combine in. So we're waiting to see what happens, and as soon as that information comes out, we'll begin in earnest on our AOB. We're not huge fans of it, especially as it comes to the providers in trying to coordinate care when we don't know all of that information. I think it's going to be onerous to figure that out. In our academic groups, it'll be a little easier, but when you are dealing with community physicians and peers that are not associated with you, it will be challenging. When it comes to the patient self-pay, good faith estimates, we have put processes in place. We've developed a central department that handles this. All of our self-pay, we've been doing self-pay estimates for a while here in Massachusetts by state law. Those old processes have now been disbanded, and the new department is taking this over for all of our entities, and it is based upon our scheduling system and information that is put in there regarding the patient scheduling type. And then that will kick off a process to develop an estimate that is based upon our historical data for those services. There are other ways that patients can obtain estimates by calling us and asking for specific information. We have had fits and starts, to be perfectly honest with you. The pandemic and hiring has definitely had an issue on us, but right now we are staffed based upon the number of estimates we have in queue. We could definitely use additional staff. We are an Epic shop, and we are waiting for some system enhancements from Epic to come through to help change the process, because right now everything is driven based upon data service, and we need it to be driven based upon date of scheduled appointment, which will help then us better manage the time frames of when we have to respond. Right now we have to do a lot of manual interpretation of what's the date of service versus when was the appointment scheduled, when is that estimate due. So we're working in good faith. It's highly complex, but the estimate is only as good as the information that you are given. And we've had a lot of fits and starts with some of them. For good faith estimates, I think we're in a good place as it relates to self-pay, but we have a lot of work to do on AOB.
Thanks, Kevin. And Ronnie, as a follow-up question for you, maybe talk about where you are with your own implementation journey at Athena Health in supporting, the good faith estimates or advanced EOBs, and maybe talk about maybe what features do you have active in production in your product today?
Yeah, absolutely. So similar to Kevin, we started looking at this about a year ago. Hope you guys can hear me. I'm getting a lot of background noise on my side. But around last summer, we really started diving into the legislation to make sure we understood it properly. As you can imagine, with software development, these things don't take 1 or 2 months to build, they take some time. So at the time we started diving into this legislation in the summer of 2021, there was a lot more detail around insured cost estimates or insured patient workflows. So that's where we started building. So what we have built and what is live today is some adjudication logic that would intercept a claim before we transfer a balance to the patient, and that is configurable by practice. And what would happen is when we get that adjudication from the payer, if that adjudication has an out-of-network patient responsibility, again, configurable by the practice if they want to turn this on, we would flag those claims so that we wouldn't send out a bill to the patient, so that the practice could review those and ensure, hey, is this the right balance that I should be transferring, or do I need to be adjusting any of this off? We also extended the insured patient workflow where we allow the practices to flag appointments ahead of time. So surfacing eligibility information, the practices would be able to say, hey, now does this satisfy the insured patient use case? And I really want to emphasize for part of this conversation that keep in mind insured patient workflow and the self-pay patient workflow are fairly different. This scope is also fairly different. So for insured patients, the legislation essentially says out-of-network providers at an in-network facility where the facility falls into a hospital outpatient, critical access point, or ambulatory surgical center. It's very different than the self-pay scenario where the legislation says, hey, any self-pay patient scheduling a visit or requesting an estimate must receive that estimate. So for our insured scenario, we allow the practices to flag which appointments will be subject to the No Surprises Act. And once they flag them, they can go in and enter in the CPT codes and the costs. And we actually digitize that CMS 10780 form, and we populate it automatically with the appointment information as well as the CPT and cost information. And we have the ability to email that to the patient or print it out. And that is a foundation as we're continuing to build out cost estimation to automate all of this. So in a future state, when you have that scenario where a appointment is actually subject to the No Surprises Act, you can go in and say, hey, generate my patient consent form and send it to the patient without even having to enter anything in. But just being very transparent, we're still building cost estimation across the board. The other thing that's almost ready for alpha, we have a couple more months, is self-pay cost estimates. So we have the capability where you can enter in CPT codes, and we will go in and fetch that cost out of the fee schedule so that we can surface those estimates to patients for self-pay ahead of time. And of course, all of this, is just part of a longer vision and journey and roadmap of producing cost estimation across the board for any type of patient. I'll pause there to keep it brief. Hopefully that answers the question, Taha.
Yeah, thank you, Ronnie. And maybe as a follow-up, looking at, you mentioned, being able to digitize some forms to help automate some workflows, and then also looking at, different code sets to use to help support, the delivery of information. So kind of building off that, what type of technologies or standards, are you looking at using? Are you looking, as you look at the future state of the build out, are you looking at APIs, some of the HL7 implementation guides, X12, or, are you working internally within your own organization to determine, what sort of standards or technologies to support implementations? Are you getting any specific requests from your clients?
Yeah, sure. So we are always API first. Whenever we build any solutions, we want to build them in a way where it is not limited to just, the team that has built it, but across our organization and then eventually externally. We have been certified this year for the FHIR standards under the 21st Century Cures Act. And in terms of just general like HL7, we had been attending a lot of the Da Vinci forums that are held weekly for cost transparency. And I think Kevin kind of hit it earlier, hit the nail on the head of, we haven't actually started doing some of that kind of advanced EOB work, via HL7, partially because I know that the implementation guides have kind of started to, or I'm not sure if they're in a complete status yet, but they've started to become defined. However, having an implementation guide is one thing, having adoption is another. So, we didn't want to wait for the greater, healthcare industry to adopt these implementation guides and have the ability to share this information. So for now, a lot of what we built have been kind of API first internal to our organization, but we're always being very mindful of how we can expose these things externally over time. We have a very large marketplace at Athena with a variety of vendors and marketplace partners that we have externally facing APIs, which includes all of the, the FHIR work that we did. So any of the work that helped us get certified for FHIR is available external to the Athena ecosystem.
Great. Thanks, Ronnie. And I think that, your insights kind of will help, different organizations kind of listening to this and, figuring out what their implementations are to kind of, what that thought process may be for their implementation experience with machines. A follow-up question for you, Kevin. You mentioned earlier about working with your EHR vendor and kind of waiting for enhancements. Maybe could you talk about how much did you have to coordinate with your vendor to ensure as you work to implement features and ensure some of your desired workflows and some of those positive outcomes? Can you talk about that vendor coordination that you had to undergo? Kevin, and you may be on mute.
Okay. First, let me say that I am not the technical guru. I help facilitate the communication, but I can tell you our teams are in constant communication with our vendor in trying to bring about changes or things that we need. We do have a large local IS team that is working and implementing workflows, but it's right down from the schedulers through the physicians, through our IT departments in trying to find the best processes that work. I think as things are being developed, Epic is changing and moving things along to create the customization that we need, as well as doing things that meet everybody's needs. And so we are waiting on some of those things, but in the interim, we are doing workarounds to make it fit our needs for what we need to do right now.
Great. And then maybe earlier you talked about being able to support and provide estimates of self-pay patients. Do you know what % of patients are requesting or being provided with good faith estimates based on kind of where you are today?
So if the patient is truly registered as self-pay, everyone is getting an estimate. It's those patients that are registered as self-pay, we generate the estimate and then they say, oh, here's my insurance, and they plug it in. I can't give you a percentage per se, but I can tell you that as of last night, we had 3,000 estimates trying to be prepared to meet the 3-day window. Now we have hundreds of thousands of appointments, but we have a staff of 8 people that are working on these estimates.
Great. It seems like you've made a lot of progress and put in a lot of effort to make it happen. So with that, I'd like to pass it off to Caitlin, who kind of will manage some conversations around maybe some of the challenges and lessons learned and maybe some of the best practices that you have from your organizations. Caitlin?
Yeah, thanks, Saha. Kevin, I'm going to come back to you. So you just talked about the % of patients receiving good faith estimates, but as you have been implementing this workflow for uninsured patients, did you experience any challenges to ensure the good faith estimates were being generated as intended?
Yeah, I think they definitely are being generated as intended. The patient's level of understanding our estimates puts a lot of onus on the practice to explain, and what we've learned is how we have to tailor our estimates. We would get a request that the patient needed an MRI of the head and neck, so we would do a head and neck MRI, send it out, but then at the time the the service was done, it had contrast. And so all of a sudden our estimate is wrong. So, we had to make decisions as to, do we quote our estimates to be over? So that way we are protected with the $400 window. So now all our estimates go out, for radiology with contrast, knowing that if they don't have contrast, it will be lower. But having the front desk trying to explain to a patient what contrast is all about and why they need contrast versus why they don't need contrast, that's been a huge challenge from the perspective. Or they're going in for surgery, and when the physician gets in there, it's way different than what was originally anticipated. So the estimate is not right at all. And so therefore, we have to kind of say to the patient, well, it was an estimate based upon the information that we had, and therefore X, Y, and Z happened. It's hard from that perspective, and that falls on the practice and the physicians to educate. So that's one of the biggest challenges that we've had.
Yeah, I can imagine that would be very hard to pivot to that sort of education. But in that respect, have you heard of any positive stories from patients who received good faith estimates?
You know, I would like to say I have, but I only get the problems. But I do know that they are being generated, and you know, I only go on hearsay of some of my employees who have had family members who say, "Yep, we got one. Didn't really know what to do with it, but they did have it." So nobody likes our charges, and they don't understand what they all mean, and so we just have to figure out education down the road.
It's great information, Kevin. Thank you. So Rodney, as you and Athena Health have worked to implement features of good faith estimates, what sort of roadblocks did you encounter and how did you navigate them?
Yeah, so we're still building automation of good faith estimates right now. The extent of what we have is actually asking the practice to tell us, hey, here is the CPT code and here is the cost, and then we go in and we populate that CMS 10780 form, which again is the one for insured patients. We're in process of building self-pay, and we have our self-pay cost estimates, and we have our roadmap longer term for automating the insured one. What roadblocks I see and anticipate is going to be, of course, just making sure we're applying the right eligibility information, right? I think for self-pay cost estimates, I'm slightly less concerned because we have the fee schedules for our practices. That's what we send to the payers when we send out a claim. So that's actually not a very complex activity to go in and say, okay, here's the CPT, therefore here are the costs. But when we move on to insured cost estimation, a copay is not a copay, a deductible is not a deductible. It kind of depends on what type of service the patients are getting, right? So we're actually expanding a lot of our eligibility solutions right now for, insurance benefits coverage so that, we don't just say, hey, what is Taha's eligibility, but, what is Taha's orthopedic eligibility, or what is Taha's behavioral and mental health eligibility? So we need to be very mindful that when we're building these cost estimations, that we are applying the appropriate eligibility for the service that the patient went in for. So I see that as definitely going to be a tricky obstacle that we'll work through. Beyond that, just staying up to date with the legislation, right? So we, as everyone probably on this call knows, right, there's been constant churn since last year and through this year of, here is the next set of legislation, or this thing is going to get postponed, or this thing is going to change. So, we work very closely with our legal team. I've been probably bugging Taha as well throughout this year and a variety of others in the community. So, just making sure we have a proper understanding of the legislation, so we're focusing on the top priority things first.
Great, that was a very comprehensive answer. Do you have any other maybe strategies that you can share with how to ensure the successful implementation of good faith estimates?
I think that we're also always considering alternative options, right? So like I mentioned earlier, attending the forums that Da Vinci holds and understanding what exists in the larger community beyond the walls of Athena, and seeing whether it's different standards that have been implemented, or even just payer APIs that exist. We always try to be mindful that sometimes it makes sense to build things in-house. Sometimes it makes sense to take advantage of things that exist in the larger healthcare community. So just trying to, I think, stay on top of what is available across the industry, and not just trying to think that, hey, we have to build everything from the ground up, because that's not always the case.
Yeah, that's a really good point about using all of industry. And with that, I will now ask Kevin, in terms of strategies, since the delivery of the good faith estimate does involve multiple parties within an organization, what strategies or recommendations do you have in ensuring that you have the right people involved to ensure the good faith estimate is as complete as can be?
Yeah, great question. We had, when we started this process, it was really driven from the revenue cycle back-end perspective in the patient accounts departments, and we tried to dictate to the front end what they should be doing with regards to this. And we quickly learned that we needed to have a more interdisciplinary type approach. And we created, different work groups to look at this and really started to engage the front end practice operations to participate in this. As it relates to NSB as a whole, we took a very streamlined approach in our identification of this from a state perspective, and focused on, the plans that, we're not participating with, and then the downstream effects with, as it relates to self-pay patients. We think we have the scripts and the consent forms and those things nailed. And now it's, all right, how do we bring everybody together so that we're all stating the same thing? So we're going to the different councils within our organizations to educate the physicians, the practice operations folks, the training departments, so that we can all, preach isn't the right word, but we can, speak from the same document. Academics are very different than the community with a lot of private physician percentages. Our specialty hospitals are different, so we have to tailor it a little bit. But the reality situation it is the communication should be the same to the patients and be able to describe that information. So we really have gone to these work groups that are made up of a variety of different types of people to participate in the conversation so that all aspects of the patient experience is addressed in our processes. We did find that we would put recommendations out there and say this is going into implementation, and then physicians would go back and say, excuse me, no, I don't think so. So we learned some hard lessons from that, but I think we are all now working together, recognizing that information is not as clear cut as everybody would like it to be, but we are working and bouncing things off of one another.
That's a very good way to understand it all. And I know we don't have much time left, so I will pass it back to Taha to help with the discussion on the roadmap for new requirements.
Yep, and looking to kind of, wrap things up, the conversation up and talk about next steps and what does the future look like. I know Kevin and Ronnie, you both alluded to, what your plans are for the future and what's next on your priority list, but maybe if you want to spend some time to go into more detail. Maybe Ronnie, if you want to talk about first, earlier you mentioned about the need to continue to monitor the different regulations and policy briefs that come out. What sort of recommendations do you have for organization as they consider developing and responding to the new policy updates, and how do you then level that within your own organization as you look to your own roadmap for new requirements?
Well, that's a good question. I think the two big pieces that, the boulders in my mind that we need to get past and do well is one that we've talked extensively about today is cost estimation. But the other one, and this is applicable a bit more to the insured patient workflow, but it's still relevant, is just the provider network. I know Da Vinci community has also, worked through some implementation guides here, but one of the challenges that we also face is that we don't have any automation to tell our customers to say, or the health practices basically, hey, here is an insured patient that is coming in for an appointment that's subject to no surprises versus not. And part of that is not absolute clarity and confidence on the provider network itself and compared to the insurance plan. So when we look at a patient's insurance package, sometimes it's not always so clear cut and dry of having the information within the Athena ecosystem to say, hey, is this provider in network or out of network? Because again, that insured patient workflow is only for out of network providers in an in-network facility, again, with a handful of facilities that remain in scope. So having good clarity around your provider network is also going to certainly help for that insured patient use case. And I think we just need to deliver on cost estimation. Like that goes beyond even no surprises. Like everyone is going to benefit from that in the entire community. When we have transparency, we have less surprises. We have increased probability of making sure patients pay their bills. And I'm sure everyone on this call knows if you don't get that patient payment within the first 30 or maybe at most 90 days, that probability drops significantly to whether or not you're going to get that patient to pay their bill. So if we have cost estimation, we have transparency, and we're not surprising patients, and hopefully we see increased patient pay yield across the industry.
Thanks, Ronnie. Really well said. And Kevin, I know we have a few minutes left, but I just wanted to give you the opportunity to see if you had any closing comments as you look to roadmap for next steps.
Sure, and I'm not going to repeat what Ronnie said, and I agree with it wholeheartedly. Here in the state of Massachusetts, we have to deal with a whole set of statewide legislative initiatives that are coming at us with regards to this that have kind of been delayed. We don't have a team that's dedicated just to no surprise billing. So it's a part of everybody's job. So then managing the competing priorities. Look, we're all about to get smacked in the face when the pandemic ends and telehealth gets revised and how we handle all of that, which will be into no surprise billing to a certain extent. So we're dealing with the state initiatives, competing priorities. But two areas that I will become focused on will be the whole rate arbitration process with regards to those payers that we are not contracted with, who are going to pay us some rate. Managing that and looking at those to determine, are they fair and equitable, or are they paying us, a Medicaid rate? And the other area that we've just started to really, as it relates to estimates and is as large academic medical centers and facilities, there's a lot of things that happen that are not known to a lot of people outside lab billing. So if we send lab tests out to the Mayo Clinic, all of a sudden a patient may be getting a bill that we wouldn't normally know about. So how do we bring that into the no surprise billing, good faith estimate process? We have some of our surgical departments have remote monitoring groups that are doing certain things for them that we don't know anything about, and they're located in another state. And so all of a sudden patients are getting bills and they're like, what is this? So that is going to be a major operational piece that will affect both self-pay as well as the insured population. So those are some of the things that I'm going to be getting focused on, but we will continue our education. And then the last thing, as a national referral center, we can manage our Massachusetts payers and those things that we're not participating with, but when we have these referrals coming from all over the country, we have to figure out now, what is our no surprise billing process with these payers in terms of whether we accept the patients into the system or not? Will we do it without prior authorization, single case agreement? Do we require deposits? These are major changes to the way the Mass General Brigham has historically done its business, but no surprise billing has pushed that to us, that we have to have this communication up front. And so a lot of that on the physician side is handled by my department, so we're going to have to work on that as well. So more operational focused issues, I think we will be focused on here in terms of the changes that are coming.
Thank you, Kevin. And both Ronnie and Kevin, I think you both had insightful perspectives to share, and good next steps for all of our audience to consider, as they evaluate their own implementations. And I know we're at time, but I just wanted to thank you both again for participating in the discussion today and sharing your implementation perspectives with the audience. And Daphne, I'm going to transition the slide back over to you to wrap up with next steps.
Thanks, Saha. And just want to reiterate our thanks to Kevin and Ronnie for joining us today and keeping this conversation ongoing. We've received a lot of questions and feedback from our audience, and we'll definitely follow up with you all. I do want to share that we have a few more education sessions and events coming up later in November, we have a webinar with CAQH Core board member Margaret Schuler. And then on November 16th, we have a CAQH Core participant forum. Tomorrow, we will be presenting a spotlight at WEDI, where we'll be focusing on the rule package we're sending to NCUHS for consideration for federal mandate. With that, I want to thank you all for joining us today and give a final thank you to Ronnie, Kevin, Caitlin, and Taha. Thanks, everyone.
Thank you.
Thank you. Thanks for having us.